Good evening, and thank you for joining us for this important discussion on physician-assisted suicide entitled Deadly, Not Dignified, Fighting Physician-Assisted Suicide in Maryland. My name is Molly Sheehan here on behalf of the Maryland Catholic Conference, and we are honored to host this incredible panel. Tonight, we are joined by three panelists and national experts on the theme of physician-assisted suicide. Allow me to introduce each of them. They're incredible individuals. Dr. Marie Albert-Borsico grew up in Brooklyn, New York. She is a graduate of New York University, Howard University College of Medicine, and the Johns Hopkins University Sinai Hospital Program in Internal Medicine. She's a board-certified internist and partner of the Crossroads Medical Group. Dr. Borsico is a fellow of the American College of Physicians, as well as past president of the Catholic Medical Association. She is also the proud aunt of 3 nephews and godmother to 4. So Dr. Borsico will be joining us and discussing her experience as a physician in response to facing physician-assisted suicide. Anita Cameron is a prominent disability rights activist whom we are blessed to have with us tonight. She began working for Not Dead Yet as the Director of Minority Outreach in January 2017. She has met with national and state policymakers and written persuasively about opposition to a public policy of assisted suicide from the perspective of communities of color who experience disparities in access to healthcare. Anita was cited in the 2019 National Council on Disability report on the dangers of assisted suicide as public policy. So we're grateful for Anita Cameron for joining us and for presenting her perspective as a disability rights activist on this important discussion. And lastly, our third panelist will be Dr. Annette Hansen. Dr. Hansen is the director of the Forensic Psychiatry Fellowship at the University of Maryland and co-chair of the Maryland Psychiatric Society's Legislative Committee, where she has reviewed legislation related to assisted suicide and testified on the issue in the state's legislature. She has 30 years of experience in the provision of psychiatric care to patients in Maryland's Division of Correction and State Hospital System, and is particularly concerned regarding implications of assisted suicide laws for these institutionalized people. So thank you, Dr. Hansen, for joining us and for sharing your expertise as a psychiatrist on this topic. Audience members joining us via Zoom or Facebook can submit questions during the event via email. You can email me, Molly, M-O-L-L-Y, at mdcatholic.org. Again, Molly, M-O-L-L-Y, at mdcatholic.org. So please send me an email if you have questions for our Q&A at the end of this presentation. We will try to get to as many questions as we can during the allotted time. Now that we've introduced all of our panelists, we're very grateful to all of you for joining us. Please send us your questions. And I'd like to turn it over first to Dr. Marie Albert-Borsico, who will be sharing with us her perspective on this important topic of how we fight physician-assisted suicide in Maryland.
Thank you for your kind invitation to share my perspective on physician-assisted suicide. Suicide, as defined in the Merriam-Webster dictionary, is, quote, the act or an instance of taking one's life voluntarily and intentionally, end of quote. As this is a voluntary and intentional act, no one, including physicians, can be compelled to cooperate in the act. This act is contradictory to the natural inclination of the human being to preserve and perpetuate his life. Some commonly known synonyms of physician-assisted suicide include medical aid in dying or MAID, death with dignity, assisted dying, physician-assisted dying, aid in dying, and mercy killing. Medicine is a noble profession. Physicians are committed to the practice of medicine and the preservation of human life. The taking of one's life, even if a physician assists, is not medical care. Medicalizing death does not address the needs of dying patients and their families. Sir William Osler, who is one of the 4 founding professors of the Johns Hopkins Hospital, is famously quoted as saying that medicine, quote, is an art, not a trade, a calling, not a business, end of quote. The Hippocratic Oath is an oath of ethics historically taken by physicians to uphold specific standards. It was developed in the 5th century BC in response to corrupt practices at the time. It contains a clear prohibition against this practice. It states, and I quote, "Neither will I administer a poison to anyone when asked to do so, nor will I suggest such a course." Physician-assisted suicide underscores the sentiment that certain lives are expendable. This includes the most vulnerable members of society, such as the elderly, the disabled, the poor, members of minority groups, and children. Physician-assisted suicide harms the patient-physician relationship, and undermines trust in medicine. The centrality of the patient-physician relationship is to be respected, as it serves to protect the dignity of the human person. The passage of Oregon's Death with Dignity Act in 1994, which legalizes physician-assisted suicide, made this the first U.S. state and one of the first jurisdictions in the world to permit some terminally ill patients to determine the time of their own death. There are many reasons why a dying patient may request assistance in hastening their death. Some include fear of losing their autonomy, fear of losing their dignity, an inability to engage in enjoyable activities, fear of being a financial burden to their families and/or society, and fear of suffering pain. The act itself typically is accomplished when a physician intentionally helps a patient who has been deemed to have 6 months or less to live from a terminal illness to commit suicide by prescribing drugs like barbiturates or sedatives. The patient fills the prescription and voluntarily consumes the drugs, resulting in their death. So these drugs include typically the barbiturates like secobarbital, pentobarbital, and these were popular sedatives from the 1960s and 70s. Also opioids, which are typically used to alleviate pain. They're very addictive, as many of you know. In fact, we are now currently battling an opioid crisis in this country. The duration of these drugs in the dying process is unpredictable. So oftentimes a cocktail of drugs is prescribed, which may include an antiemetic, which is used to counteract nausea, an anti-seizure medication, and a barbiturate or opioid. An example of such a cocktail is DDMP, and this stands for the drugs diazepam, digoxin, morphine, and propranolol. This cocktail is designed to put the patient to sleep and then stop their heartbeat and breathing. This cocktail is more reasonable financially, as it typically will run about $300 to $600 or maybe a little bit more than the traditional 100 capsules of segobarbital, which may easily cost $3,500 or more. There are a number of inherent flaws in this practice. Some include the definition of a terminal illness. This doesn't also, this not only includes cancer, but if you had, for instance, a 19-year-old who is an insulin requiring diabetic, if they decide to stop taking the insulin, well, their diabetes becomes terminal. So they would qualify for the physician-assisted suicide. The patient is not required to notify their loved ones of their intent to commit suicide. And so oftentimes they die all alone. The physician who writes the prescription is not present during the event and merely gives the patient instructions on how to ingest the medications. There are instances in which it has taken several days for the patient to die after consuming the pills or cocktail. The process is not painless. There are instances where consuming the medications has essentially burned the throat of the patient. A psychological evaluation is not mandatory of the patient who wants to commit suicide. And there are effective ways today of managing the depression and or anxiety that patients experience as they approach the end of their lives. Today, we can effectively manage pain through palliative care and provide for the comfort of the dying patient through hospice care. What happens to the drugs if there are any left over? Our children or adolescents, will they have access to the leftover drugs? The physician who participates is typically not the one who has a long-standing patient-physician relationship with the patient. The physician is expected to falsify the cause of death on the death certificate by attributing the death to the underlying medical condition. Under ordinary conditions, the falsification of a death certificate would be considered a felony. In this instance, the physician is protected. Modern healthcare systems are motivated by money, and insurance companies don't necessarily like paying large amounts of money for treatments. So one can see the temptation to drive a patient to seek this course to save money in their medical care. The American Medical Association is the largest physician professional association in the country. It asserts in its code of medical ethics that physicians are encouraged to aggressively respond to the needs of patients at the end of life. Physicians should not abandon a patient once it is determined that cure is not possible. Physicians must respect patient autonomy. Physicians must provide appropriate comfort care and adequate pain control. The AMA a few years ago also affirmed its opposition to physician-assisted suicide. The American College of Physicians, of which I am a member and fellow, is the largest medical specialty organization and second largest physician group in the United States. It does not support the legalization of physician-assisted suicide or euthanasia. It also clearly states in its ethics manual that patients rightfully expect their physicians to care for them as they live with eventually fatal illnesses. So finally, I just want to stress that most physicians, thankfully, are not willing to participate in physician-assisted suicide. Physician-assisted suicide is not medical care. Physicians do not kill, we care. Suicide is not dignified. Patients have been known to outlive their prognosis of 6 months or less to live. And today, we can effectively eliminate suffering without eliminating the sufferer. Thank you.
Thank you so much, Dr. Busico, for that great presentation and for really summing up some of the concerns about the loopholes in the bill and just, yeah, there's a lot of concerns about how we go forward and how we treat people in our state. So thank you for covering those issues. All right, I'd like to turn it over now to Anita Cameron. Ms. Cameron is a disability rights activist, and we're so grateful to her for joining us. She is going to be addressing this topic from her perspective. And so without further ado, I'd love Ms. Cameron, please take us away.
Thank you. I'm actually going to read so I'm Anita Cameron, Director of Minority Outreach for Not Dead Yet, a national disability rights organization opposed to medical discrimination, healthcare rationing, euthanasia, and doctor-assisted suicide. Assisted suicide laws are dangerous because though these laws are supposed to be for people with 6 months or less to live, doctors are sometimes wrong about a terminal diagnosis. My mother, while living in Washington State, was determined to be at the end stage of chronic obstructive pulmonary disease. I was told her death was imminent, that if I wanted to see her alive, I should get there in 2 days. She rallied, but was still quite ill, so she was placed in hospice. Her doctor said that her body had begun a process of dying. Though she survived 6 months of hospice, her doctor convinced her that her body was still in the process of dying, and she moved home to Colorado to die. My mom didn't die. She became active in her community, and she lived almost 12 years. Assisted suicide laws put sick people, seniors, and disabled people especially at risk due to the view of doctors that disabled people have a lower quality of life, therefore leading them to devalue our lives. Now, add race and racial disparities in healthcare to this. Blacks in particular receive inferior healthcare compared to whites in areas of cardiac care, diabetes, cancer, and pain management. As a Black Latina, I didn't see assisted suicide as part of my culture. This was borne out in a 2013 Pew study that shows that Blacks and Latinos are 65% opposed to doctor-assisted suicide, and in states where it's legal, rarely use the program. Doctor-assisted suicide proponents tend to be white professionals and managerial class folks. What's especially dangerous is that in states where it's legal, if you lose access to health care, turning your chronic condition into a terminal one, you can request assisted suicide. It'll be cheaper to kill you than to care for you. Here are the top 5 reasons people ask for doctors assisted suicide. This is according to the Oregon data. Oregon has had their assisted suicide law for 23 years now. But the top 5 reasons are loss of autonomy, a loss of dignity, loss of the ability to do things they once loved, loss of bodily control, such as incontinence and vomiting, the feelings of being a physical, emotional, or financial burden on family peers and caregivers. All of these are disability related issues that can be addressed with home based care services and supports. Proponents speak of pain as their number one reason why they want doctor assisted suicide. Yet, according to the data, pain or the fear of pain was seventh on the list. And that can be addressed by effective pain control, palliative care, hospice services, and palliative sedation. Assisted suicide laws are deadly public policy. And as long as disability discrimination and racial disparities in healthcare exist, doctor assisted suicide has no place in Maryland or indeed in our nation. Thank you.
Thank you, Anita, for your presentation, and we look forward to asking more questions about how physician-assisted suicide affects people with disabilities as we move into the Q&A. But before we get to that, I'd like to introduce our third panelist, Dr. Annette Hansen. Dr. Hansen is a psychiatrist, as I mentioned before, and so she will be sharing her perspective, and then we'll open up the panel for question and answer. So thank you, Dr. Hansen, for being with us, and please feel free to tell us your thoughts on this topic.
Thank you so much for the opportunity to speak to you today. I always have to begin with a standard disclaimer, which is that I will be expressing my own personal opinions, not the opinions of my employer, my academic institution, or any professional organization I'm affiliated with. So what I'm going to be talking about today is the effect of assisted suicide laws and the right to die movement on people with mental illness. And the first point I want to make is that even in states that haven't yet passed the laws, just the publicity surrounding the movement itself has already had a detrimental effect on people with mental illness. It's important to understand this because there have been several studies about suicide contagion or the issue of mimicry in assisted suicide and suicide deaths generally. There was one study of a systematic review of 56 studies looking at the effects of media coverage on suicides. And what they found was that in the vast majority of studies, the media coverage of suicidal behaviors and actual suicidality were definitely associated. There were only 4 studies that found no significant associations. That has been taken into consideration by the Centers for Disease Control. They've published guidelines for the media on how to cover stories about celebrity suicides. So they recommend that when journalists cover suicides, they don't present it in a very glamorized or remote romanticized way. They should not discuss the means of suicide. And this is what they recommend to avoid the risk of contagion. Now, the Right to Die movement took just the opposite approach. So in 2014, Compassion and Choices essentially fashioned a membership campaign around a celebrity assisted suicide death. The infamous story of Brittany Maynard. She appeared on the cover of People magazine talking about her desire to die, her promotion of assisted suicide laws, and they Compassion and Choices created a donation and membership website around this. Her story was so popular worldwide that when the site went live, it got hundreds of thousands of hits in the first hour. The server was almost being shut down. There were so many people requesting access to the website. They actually had to take the web page down. Similarly, here in Maryland, we had another case, a very infamous case of the late Dr. Lawrence Egbert, who, acting as medical director of the Final Exit Network, admitted that he had been a participant in as many as 100 assisted suicide deaths nationally. Here in Maryland, he was involved in 6 deaths. 3 of those people were not terminally ill. They had clinical depression. And he said in his interview with the Washington Post that he supported the idea of assisted suicide for people who weren't terminally ill solely on the basis of mental illness. So I want to make a strong point that there are hopefully rare physicians who would be willing to do this. This is not a scary, slippery slope hypothetical. We've already had a case here in Maryland. You've heard a lot about the reasons why people might request assisted suicide. I'm going to take that one step further. As a forensic psychiatrist, I work in state institutions. I work in a prison, I work in a state psychiatric hospital. And generally speaking, the majority of these patients, there's a high prevalence of serious mental illness. The length of admission can be measured in years rather than in days or weeks like a traditional hospital. The prisons now have a very high percentage of elderly people, and I always cringe when I say this. Elderly in prison terms means over age 55. Several of these people have comorbid conditions, chronic health conditions like heart disease, hepatitis, diabetes, and HIV. Many prison systems now have hospice or palliative care units. When I have spoken to one retired medical director of a prison system on the West Coast that had an assisted suicide law, he told me that there had been requests from 3 or 4 prisoners for lethal medication while they were incarcerated. He made a very interesting point that I hadn't considered. Under these laws, these people are allowed to take the medication at the time and place of their choosing. So theoretically, if they had granted these people a lethal prescription, they would have had to allow that prisoner to carry that medication with them 24/7, even on an open tier. There would have been no way to guarantee that that person was actually the one taking the lethal medication. Within state hospitals, it's important to understand that psychiatric facilities where there's a long length of stay are small communities. Everybody knows what's going on in the facilities. The patients talk to one another. Many people don't realize that even people with mental illness who are civilly committed to a psychiatric hospital, from a legal standpoint, they still possess decision-making autonomy for medical care. So being civilly committed does not restrict in any way their ability to make decisions about medical treatments. And so people who are committed to hospitals, in theory, could be allowed to have lethal medication or even to take the medication in the unit. Now, imagine having a loved one on an inpatient unit, committed there for their own safety, who might be at risk of suicide, might have a severe depression. Imagine if that person finds out that their doctor actually is prescribing lethal medication. That's also undermining the care of people with psychotic illnesses, people who might have a delusion that their doctors are prescribing poison. If a doctor really does prescribe poison, you're reinforcing a delusion, and that's very bad for psychiatric care. Now, some of the reasons that you've heard for requesting lethal medication for medical patients also apply for people who are in state facilities. You've heard about loss of autonomy, inability to engage in enjoyable activities. Well, if you're in a secure facility like a prison or a state hospital system where you may or may not be allowed to leave the unit, you're restricted from the freedom to associate with the people you want to, you don't have access to any of the hobbies you used to enjoy, that carries over. There are definite parallels. You've heard about fear of loss of dignity or fear of loss of bodily functions. If you're working in a state facility, you're told when to get up, when to eat, when to go to bed. You have loss of autonomy. You have loss of bodily functions. You can't go to meals whenever you want to. When it comes to fear of being a burden on others and financial concerns, that's definitely a situation. Anyone who's had any medical admission knows about surprise billing and the cost of medical care. So any of these motivations that apply to medical patients also happen for people with serious mental illness. You've already heard about the stigma of having a physical disability, the fact that people with disabilities and people with minority people with disabilities aren't offered the same level of care as people without that problem. The same holds true for people with serious mental illness. In general, people with serious mental illness do not live as long as people without these psychiatric conditions. That's because they're often not able to access routine medical care. When they have a chronic problem, they may not be offered the level of care that's offered to someone else. And they're not always offered life-sustaining care the way people without mental illness might be. So there are direct parallels between people with medical conditions and people with psychiatric conditions. A lot of people also don't realize that there are psychiatric conditions that are lethal, that can be terminal. Specifically, people with eating disorders. Eating disorders like anorexia have, if left untreated, have some of the highest mortality rates. And there have been people in this country who have been released from civil commitment in order to die of their eating disorder in a hospice program. So in states where this is legal now, like New Jersey and Colorado, where they have severe treatment-resistant eating disorder programs, in theory, those patients could now ask their doctor to approve them for lethal medication. Now I'm going to give a couple of examples. When I talk about this, I'm sometimes accused of discussing scary, slippery slope, hypothetical problems. And the point that I want to make is that these are not hypothetical. Some of these situations have already come up. So a few years ago, there was one Tennessee prisoner who was serving life for felony murder. And he, on his own, filed a motion with the court to request death with dignity in the form of euthanasia so that he could donate his organs to his elderly parent. That motion was not granted. He did not do that. But it would be very ironic here in Maryland, now that we've gotten rid of the death penalty, if we then substitute a voluntarily self-induced death. Similarly, here in Maryland, not too long ago, our bill failed by one vote. It came very close to passing out of the General Assembly. And again, that was a very highly publicized issue. The bill was covered, it was reported in the news, and people in psychiatric hospitals, they see the news, they read the newspapers, they know what's going on. On the very day that that bill died in 2019, one of the patients in one of our psychiatric hospitals asked his doctor to prescribe a lethal medication. Now, fortunately, the bill failed, but could you imagine if it had passed? How would the state have reacted? Would my colleague have been required to approve this person for medication? Would he have been required to assess capacity to make the decision? Would the hospital have been required to provide the scene and means of death in a facility dedicated to preventing suicide? I'm going to wrap up with some recommendations for advocacy. I would first of all encourage all of you, if the bill is resubmitted this year, to speak to your elected officials about the role of state institutions. If this passes, you cannot deny a legitimate medical intervention to someone just because they're incarcerated or just because they're in a psychiatric hospital. That's unconstitutional. So our politicians need to think about, how is the government going to carry this policy out in their state facilities? What will they do when every single physician employed in those facilities refuse to participate, which is their right? Will those doctors be mandated to carry this out? Will they have to pay money to hire outside consultants to carry it out? These are the things that people aren't considering. The other thing you need to think about is that in state facilities, there's a federal law called the Civil Rights of Institutionalized Persons Act. It's also called CRIPA. And under CRIPA, state facilities are required to prevent suicide. So on the one hand, if you don't provide it, you risk violating the law because this is a state created right. If you do provide it, you risk violating federal law for violating a federal civil right. You'd be damned if you do and damned if you don't. This is a complicated legal situation. I would encourage you to get your elected official to consult with the state attorney general to get their opinion about this. And that will highlight the contradictions that this policy creates. I would also emphasize, when you're talking to your elected officials, talk about the existing safeguard failures. You've heard a lot about the problems with the law, but again, you'll easily be accused of a scary, slippery slope hypothetical. But we know that there have been failures. In 2016, the newspaper Des Moines Register looked at the records of all the assisted lethal medication prescriptions in all the 6 states where it was legal at the time. And what they found was that in hundreds of deaths in the 6 states, the records were either completely non-existent or incomplete. And their conclusion was that this problem made it impossible to decipher whether or not the law was being followed. Similarly, when you look at the first year of data coming out of Colorado, when they passed their law, what they found when reviewing cases was that in 13% of the cases, the medications were not being reported to the state at all by the physicians, although that was a requirement of the law. They also found that in 47% of the cases, there was no written request, which was mandated by the law. And in 61% of the cases, the required second opinion by a consulting physician was completely missing. So in 2/3 of the cases, the law was not being followed in Colorado. Now, in spite of that, every single physician who wrote a prescription attested that they had followed the law. They said they followed the law, but they didn't. This is not a scary, slippery slope hypothetical. This is the reality. Doctors are not following the law, and this is happening without consequences. So these are the issues that you should bring up when you speak to your elected officials. And with that, I think we are going to take questions now.
Excellent. Thank you so much, Dr. Hansen, again, for just sharing your perspective, especially from state psychiatric institutions. It's very unique and interesting to understand that the difficulties that this law, if it were passed, would face in those institutions. So again, if you in the audience would like to submit questions, there's still time. You can email me, Molly, MOLLY, at mdcatholic.org. Again, Molly at mdcatholic.org. We have some that have come in, so we'll go to those now. The first one I'd like to direct to Dr. Busico. Doctor, we received a question asking about how the Maryland bill deals with self-administration of the lethal medication. So a person has to self-administer. What does that mean? Does it mean the person has to hold the cup, or how does that work? And would it apply with tube feeds?
Would it apply to tube feeds? Okay. Well, so what this means is, so if a physician writes a prescription for you, okay, you have to, or the patient is supposed to present at the pharmacy to pick up the prescription. There's no guarantee that it's always the patient who's doing that, but the patient is expected to pick up the prescription. The patient is also given instructions by the physician on how to consume the medication. So the physician is not present during this event. The patient does not have to notify their family, so they're often all alone. Um, in many instances, when you were just consuming 100 capsules of secobarbital, for instance, you'd be given instructions to break all of those capsules into juice or something that'll make it palatable, and then drink it within, a certain amount of time. So that's the way it's supposed to happen. There's no guarantee that it does.
Thank you. That's helpful. All right, another question that we've received is just a general question. So I'm gonna send this to Dr. Hansen. What if someone is in pain? This is I think this person was trying to address, one of the common concerns. If someone is in pain and they are, they want to use physician-assisted suicide, wouldn't this be a good idea? So how would you respond to that question?
Right. So I have a couple different responses. First of all, there's no good reason for someone to be in intractable pain. I'm not a palliative care physician. I don't provide end-of-life care as far as that goes. The second point I would like to make is that under this law, once you make pain or suffering the basis of a lethal prescription, then you've automatically roped in people with mental illness. So if suffering is allowed for physical pain, people in psychiatric hospitals also have psychological or emotional pain. So to discriminate on the basis of arbitrary physical versus mental suffering, you're opening a hornet's nest right there.
And again, we have effective ways of managing pain today. So there's really no reason to use that as an excuse for physician-assisted suicide. We have excellent palliative care services and also hospice care to keep a patient comfortable. So there really is no reason to ever say that you're in such pain that you should die.
Thank you. All right, I have a question to direct to Anita. So this person is asking with regards to the cost of healthcare and how that affects people with disabilities and minority communities. That, are there any examples of how this has affected people in other states?
Well, there have been instances in Oregon that I know of, in California, where insurance companies decided to deny people receiving cancer treatment. They decided to deny them their chemotherapy and to suggest, among other options, the assisted suicide drugs. One woman from California had her treatment denied days after California uh, instituted their assisted suicide law, and she asked out of curiosity what the copay for the assisted suicide drugs, and it was $1.20. So some of the consequences are insurance companies will deny people care who don't uh, want assisted suicide. Uh, and also, uh, that's another danger is that if you lose access to your meds, I believe diabetes, there was a question asked to the Oregon Division of Health about people losing access to their meds, would they be eligible to request for assisted suicide? And that answer was yes. and not only lose access to your meds, but if you decide, I don't want to do this treatment anymore, then if you live in a state where it's legal, then you are then open to assisted suicide. So the our healthcare already, it depends, it's very bottom line focused, the insurance and all. And so that's a danger as well, because remember, one of the reasons that people ask for this is they're afraid that they're going to be not only a physical or emotional burden, but a financial burden. And this tends to happen, you look at communities of color or disabled folks who are more likely to be poor, who are more likely to, not have private, insurance, more likely to have Medicaid or Medicare. And as someone who uses those programs, I can tell you get denied the treatment a lot, and so this is where it's going to hit communities of color. This is where it's going to hit people with disabilities, and we won't even, go into the whole um, disability discrimination in healthcare and racial disparities in healthcare that factor into this, that fuels into this. So yeah.
Thank you. It's really helpful. All right, I have another question. This one is I'm gonna send to Dr. Hansen. So this person is asking, what does it mean that the Maryland bill, they've heard that the Maryland bill does not have a system for reporting abuse, that doctors, witnesses, and family have full immunity. So what does that mean? Is that the case? Your thoughts?
Yeah, the bill doesn't have any whistleblower protection. So a healthcare provider who is aware of coercion or aware of an improper prescription or aware that a doctor is not following the law, there's no mechanism to deal with that under the law and not be retaliated against. I think that's a significant shortcoming. And when it comes to consequences of not following the law, first of all, you have to detect that the person is not following the law. Our bill, Maryland bill, did not have any requirement for the health department to do any random chart reviews of the prescribing physicians to ensure that they've got their documentation in place. There's no requirement for any prescribing physician to be trained under their obligations under the law. In the District of Columbia, they do have a training obligation. So if a doctor wants to prescribe lethal medication in the District of Columbia, they have to watch a 10-minute slideshow about their requirements to fill out certain paperwork. That's basically it. And a year after their law passed, they had another follow-up hearing, and there were proponents who were complaining that this was too much of a burden to watch the slideshow. And so there are a lot of shortcomings as far as doctors trained to do capacity assessments, doctors trained to recognize mental illness. There's not even a requirement to offer even a voluntary referral for a psychiatric assessment.
Okay, that was another question that we received, was whether there is a mental health evaluation and how doctors determine whether the patient has capacity or whether they are experiencing depression. Is that possible under the bill?
Yeah, well, this is the interesting part. So what you'll hear the proponents say is, we don't need mental health professionals to do this. Doctors do this all the time when they're getting consent for medical procedures. Well, death is different. So the standard should be higher for a life or death matter like this. As a forensic psychiatrist, I'm trained to do capacity assessments. So forensic psychiatrists assess capacity to participate in a criminal trial. And an evaluation like that requires an interview with the patient, a review of medical and psychiatric records, reviews and interviews with people who might have information about the person that's relevant. And one of the severe shortcomings in this law is that under existing confidentiality law, a coerced patient can just tell the capacity assessor, no, you can't talk to John Doe. I don't give you permission. So a coerced patient can refuse a psychiatrist permission to talk to someone who has actual knowledge of coercion. That's a severe deficit. So this law, if it passed, you would have to modify your medical confidentiality laws to allow a psychiatrist to speak to anyone who might have relevant information. That's a significant shortcoming in the bills.
Wow, that is actually really scary. All right, another question that I got in, I think this one I'm going to send to Dr. Bursico. So this one, they're asking, you know, with regards to the Maryland bill, whether, yeah, this is regards, I think it's in regards to pain and suffering. But I think the question is kind of asking, you know, what options are available when it comes to pain management, and, you know, is this necessary? So can you talk a little bit about the options that are available for pain management?
Well, again, you know, palliative care. I mean, that's what it's all about, the management of pain. And the beauty of a palliative care program is you don't have to wait until you're at the end of life or about to die. You can become involved in this pain management at the very instance of a diagnosis like congestive heart failure. You know, so you can be involved in this right from the very beginning of any ailment. So you don't have to be terminal or at the end to qualify to participate in palliative care. I mean, the whole point of palliative care is to keep you as comfortable as possible so you can be as functional as possible. So the programs are wonderful. They alleviate pain beautifully. So that should not be the reason that one wants to die. So again, the beauty here is you can be enrolled in a program at the very beginning of a diagnosis, and it doesn't have to be a terminal diagnosis. Hospice care, on the other end, it is really more towards the end of a disease process when you are terminal, and again, just to try to keep you comfortable. But palliative care, the beauty here is that the design is to keep you as comfortable so you're as functional as possible.
Got it. Okay. And I got a question for Anita now. This question, wondering, Anita, this person's asking, with regards to the most common reasons for choosing assisted suicide, how can individuals and institutions advocate for alternative solutions, especially for minority and disabled populations? I think they're asking, especially when it comes to the reasons that people chose physician-assisted suicide in Oregon, or the reasons that people choose it. How can individuals and institutions respond?
Well, in an institution, you know, because um, a lot of people with disabilities are in uh, uh, nursing homes or intermediate care uh, facilities or psychiatric facilities, or even these adult care homes and stuff. Most of these places have ombudsmen that a person can, if they feel that they're not getting the services and supports that they need, you know, because all of those reasons are disability related um, reasons that would be that can be addressed by, if you're in the community, getting, you know, the service, the supports that you need. If you need attendants to help you or someone to help you with your activities of daily living, um, if you need uh, if you need other services, mental health services, this and that, they have for people with disabilities. Um, every community, practically, certainly every state, has what they call centers for independent living. And these are places that are ran by and for people with disabilities. They're non-residential places. People with disabilities go there to get advocacy services, whether help with getting benefits, um, getting home health care in some instances, getting different advocacy, for them, um, and so every state has those. And so uh, the Centers for Independent Living usually help disabled and sometimes elderly, although there's like area agencies on aging that states have that can help seniors, access programs, as well. Because once you have access to those programs, where somebody's coming in helping you, bathe, toilet, help you with your activities of daily living, help you remain independent. You know, when you have systems helping you to get to your doctors, to get around, you know, uh, all of these others, then you don't have um, situations where, um, where you're gonna be, dying. The problem is that um, especially in the areas of mental health, it's still hard for people with disabilities, a lot of us, to get that help, especially if you have uh, physical disabilities or if you have communication disabilities and whatnot. A lot of times, the medical profession or society in general really isn't prepared to deal with people with disabilities, but that's the reason why they have. Um, these centers for independent living ran by people with disabilities for people with disabilities, and they act sometimes as advisories to the community as well, because nobody knows disability like other folks with disabilities. And once we have those services in place, then the desire then to be in a situation where you're going to have assisted suicide, that then goes away. For a lot of people, it's about their control, and their dignity. A lot of it, it's not, pain is put out there, but pain is not as prevalent as prevalent a reason for people wanting assisted suicide. It's the whole existential um, fears of disability related uh, things of the loss of dignity, of the loss of autonomy, of that. But if, as long as we're having, and so in institutions, that's a thing too. They have the ombudsman, they have the advocate. Get to those people, um, to make sure that if you're in an institution that you are getting what you need, because a lot of times unfortunately there is neglect, but they do have patient advocates and patient ombudsmen that can help. And also that's where the SEALs come in, because they can go into an institution, the local institution, and help that person or help that person's team. So nobody's it's a lot of times if you're disabled and if you're in an institution, you think that you're forgotten, but you're not. There are places out there that help. There are places, the protection and advocacy agencies, if there's abuse or whatnot in the nursing home or in other institution, those places are around the area. Agencies on aging are around. There are a number of agencies out there that can help institutionalized people get the services and supports that they need so that they're not in a situation where they're wanting to request assisted suicide.
Thank you so much. Those are so many different options that are available for people with disabilities, and it's just helpful to know those. Thank you. I have a question. I think I'm going to direct this again to Dr. Busico. How easy would it be for people in assisted living homes to access this without their family knowing? Can the on-staff doctor offer it if an on-staff nurse is a witness? They're concerned about the coercion aspect that could be present.
How easy would it be
Yes.
for, you mean for the a resident member in assisted living to request this?
Yes.
Well, yeah, unfortunately, because there aren't that many safeguards, it wouldn't be too difficult. Now, again, you have to find physicians and maybe even nurses who are willing to participate. And thankfully, the majority of physicians will not participate in this. So you have to have a willing physician for this to happen. Yes, regrettably, the patient does not have to notify their family members. And there's really no way to safeguard an evaluation like Dr. Hansen alluded to earlier. There's no guarantee that you would be given that opportunity to be assessed to see if there's a psychological reason why you're requesting this. So again, it really involves the willingness of physicians to participate in this, and the majority of physicians do not want to participate in this because this is not medical care.
Alrighty. Another question that we have coming in is just regards to COVID-19. So, you know, we've lost over 10,000 people in Maryland this year. We know that a lot of people are also struggling with their mental health. We've seen an increase in overdoses and even Olympic athletes struggling with mental health. So I think I'll direct this to Dr. Hansen. You know, what would you say to this person? They're just raising these concerns and they're wondering if you have any comments and how this plays into physician-assisted suicide.
Well, sure. I think COVID has placed a lot of stress on people in the community who may have lost jobs, who may have lost loved ones, who may have a disabled child or relative that they're afraid of having infected. And also access to services. I mean, when people wonder what they can do about this, we need to improve access to mental health care. There's no question about that. Because of fears of contagion, a lot of people, even in private practice with good insurance, can't have a face-to-face visit with the psychiatrist because of concerns about infection. I think that's starting to change, but it has created another barrier that people have to consider. So if you want to see a psychiatrist during COVID and the only option is remotely, you better live in a part of the state that has good data coverage. You better have some savvy to work technology, okay? And that's been created a barrier for people. And so I think that has created more of an impetus for people to feel helpless or abandoned under certain circumstances.
It makes sense. It's been a tough year. So we have just a couple minutes left. So I'd love for each of you just to answer this last question and leave any last comments that you might have. This person asks, what are ways that we can fight assisted suicide in Maryland, whether through advocacy or otherwise? So Dr. Busico, what your thoughts?
Reach out to your legislators, you know, speak to your physicians, you know, encourage your physicians to speak out against this. I mean, I think that's really critical because again, physician-assisted suicide is not medical care. So reach out to those who have the power, who have the voice in the legislature. But again, encourage your physicians, because I find a lot of times physicians are not comfortable speaking out because they don't sense the support that they don't sense the support that they would need or they would like from their own patients. And they need to hear this from the patients as well.
Thank you. Anita, your 30-second take on how people can fight physician-assisted suicide in Maryland.
Talk to your friends. If you're people with disabilities, seniors, regular old people, talk to your friends, educate them, teach them how to talk to their legislators and to legislative staff and all. Spread the word to your friends that this that assisted suicides puts people with disabilities, sick people, seniors, and communities of color in jeopardy. Talk to among each other.
Thank you. Dr. Hansen?
Oh goodness, only 30 seconds. That's going to be a challenge for me. I would say right off the bat, whenever you hear someone saying it's not really suicide, I would nip that in the bud immediately. So if you use suicide when a person with mental illness kills himself and death with dignity when a person with medical illness kills himself, you've just created stigmatizing language that implies that people with mental illness values their life differently or less than people with medical illness. That's discrimination and it's wrong.
Wow. All right. Thank you all so much. This concludes tonight's discussion. Thank you to all who participated, who sent in your questions. Thank you to Dr. Maria Albert Borsico, to Anita Cameron, and to Dr. Annette Hansen for joining us. This event will be available on the Maryland Catholic Conference website, mdcatholic.org, and on Facebook Live. Thank you again, and good night.